You walked into the doctor's office last month feeling perfectly fine. No chest pain, no trouble breathing, just your regular checkup. But before you knew it, you were on a treadmill with wires taped to your chest, then sent for more tests, then facing a procedure. And a recent analysis of national health data revealed something shocking. More than half of adults over 65 received at least one cancer screening. That sounds responsible, except researchers found many of those tests were unnecessary and actually caused more harm than benefit. The solution is not what you expect, because sometimes the smartest decision for your health after 65 is to stop doing certain tests. In this video, you will discover 5 medical tests that may actually do more harm than good after 65, based on national guidelines. You will learn exactly why more testing stops being safer with age, which common screenings carry serious risks for older adults. And the last one on this list will completely change the way you think about the test everyone says you should never skip. If this information helps you make better decisions about your health, please give this video a like and subscribe to the channel. Share this with a family member or friend who might benefit, and tell us in the comments, have you ever felt pressured into a test? Here is what most people believe. Earlier detection and more testing are always better. The more screenings you do, the safer you are. But medical science has proven otherwise, especially after age 65, when the balance between benefits and harms can flip completely. Think of screening tests like a metal detector at the beach. In the right spot, it finds valuable things, but sweep it over the wrong area, and all you get is bottle caps and rusty nails, dozens of false alarms that lead to digging holes for nothing, wasting time and energy. Major health organizations discovered that for several common tests, the risks of false positives, invasive follow-ups, and overtreatment begin to outweigh the benefits in healthy older adults with no symptoms, and what matters is not your age alone, but your overall health and life expectancy. Research confirms that every test you take should answer one critical question. Will this result actually change anything in my treatment? And the good news is that you have more control than you think. And today, you will learn exactly which tests to discuss with your doctor. Test number 1. A routine resting or exercise electrocardiogram, commonly called a stress test, in people with no heart symptoms at all. If you have never had chest pain, shortness of breath during activity, dizziness, or any warning signs, this screening test is not recommended. National guidelines from major preventive services organizations state clearly that screening with electrocardiogram in asymptomatic adults leads to harms, including unnecessary invasive procedures, overtreatment, and the psychological burden of being labeled as having a heart problem when you do not. Here is how the harm happens. The test picks up a tiny abnormality, something that would never have caused trouble in your lifetime, never. But now it is on paper, so the doctor orders more tests, maybe a coronary angiogram, a procedure where a catheter is threaded through your arteries. That procedure itself carries real risks: bleeding, infection, kidney damage from the dye, even triggering a heart attack in rare cases, all for nothing. One large study tracking thousands of adults found that false positive stress tests led to invasive follow-ups in nearly 1 out of every 10 people. And the vast majority of those follow-ups revealed no actual heart disease, just unnecessary anxiety, medical bills, and recovery time from procedures. Another hidden harm is overtreatment. Once something shows up on a test, doctors often feel obligated to treat it, even if it would never hurt you. You might end up on medications you do not need, with side effects that affect your daily life, or even undergo surgery to fix a problem. That was not really a problem in the first place, and this is especially true for older adults whose hearts naturally show age-related changes. The key question to ask your doctor is simple but powerful. Do I have any symptoms that make this test necessary, or are we just checking? Because if you are symptom-free, active, and managing your blood pressure and cholesterol well, this test adds risk without adding real protection. What you should do instead: focus on proven prevention strategies that clearly help at this age, like controlling blood pressure and cholesterol levels, taking a daily aspirin or other antiplatelet medication if your doctor recommends it, staying physically active within your limits, and managing diabetes tightly. These actions have strong evidence behind them and directly reduce your risk of heart attack and stroke without the dangers of unnecessary testing. One critical warning: if you do develop symptoms, chest discomfort, unusual fatigue, shortness of breath, or any change in how you feel during activity, then the test becomes valuable and necessary, because symptoms always deserve evaluation, and this advice is only about screening in healthy people. The bottom line is that a stress test in someone with no symptoms is like checking for fire in a house where there is no smoke, no heat, no alarm. Test number 2. A carotid artery ultrasound to screen for stroke in people with no symptoms, no dizziness, no vision changes, no weakness. This test uses sound waves to look at the arteries in your neck that supply blood to your brain, checking for narrowing or blockages. It sounds logical. Find a blockage early, fix it, prevent a stroke. But major medical guidelines say the harms outweigh the benefits in healthy adults. The primary harm comes from false positives. The ultrasound finds some narrowing, which is extremely common with age and usually harmless, never causes symptoms. But once it is detected, the medical system often pushes toward more testing and procedures, including carotid endarterectomy, a surgery to clean out the artery. That surgery carries serious risks, especially for older adults. Stroke during the procedure itself, heart attack, bleeding, infection, nerve damage affecting your voice. Studies show that among people with no symptoms, the surgery causes a stroke or death in about 3 out of every 100 patients within 30 days. And here is the critical fact. Most people with mild or moderate carotid narrowing will never have a stroke from it in their remaining lifetime. Research tracking thousands of adults found that only a small fraction of those with asymptomatic narrowing ever developed stroke symptoms years later. So screening everyone means subjecting many people to risky procedures to prevent a stroke that was never going to happen anyway, pure overtreatment. Another problem is the anxiety and labeling. Once you are told you have narrowed arteries, you carry that diagnosis. It affects insurance and mental peace. You start seeing yourself as sick even though you feel perfectly fine, and that psychological burden is real and measurable in quality of life studies. The National Task Force reviewed all the evidence and concluded clearly: do not screen for carotid artery stenosis in the general adult population without symptoms. The balance of benefits and harms simply does not support it, and what matters far more is managing the risk factors that actually cause stroke. What you should do instead: focus on controlling blood pressure, which is the single most important modifiable risk factor for stroke at any age. Keep your blood sugar under control if you have diabetes, take a statin if your doctor recommends it for cholesterol, and stay active regularly. If you smoke, quitting is the most powerful stroke prevention step you can take, more effective than any screening test or procedure could ever be. One important warning: if you do experience symptoms like sudden weakness on one side, vision loss, difficulty speaking, or unexplained dizziness, seek help immediately. In that case, imaging becomes essential, not screening but diagnosis, and the test can guide life-saving treatment within the critical time window. The key takeaway is that screening without symptoms leads to a cascade of harms, but managing your risk factors prevents stroke without those dangers. Test number 3. The prostate-specific antigen blood test, commonly called the PSA test, for prostate cancer screening in men over 70 years old. This is one of the most debated tests in medicine, and the evidence in men older than 70 is clear. Routine screening causes more harm than benefit. National guidelines state that for men over 70, the increased risk of false positives, biopsy complications, overdiagnosis, and treatment harms outweigh any survival advantage. Here is why. Prostate cancer in older men is often extremely slow-growing, so slow that most men will die with prostate cancer, not from it. One major study followed thousands of men for over a decade and found that screening did not reduce prostate cancer deaths in men over 70, but it did lead to a cascade of harms, starting with false positives. An elevated PSA level does not mean cancer. It can rise from infection, inflammation, or just normal aging, but once the number is high, the next step is usually a prostate biopsy, a procedure where needles are inserted through the rectum to take tissue samples, and that biopsy is not minor. Studies show that serious complications occur in about 1 out of every 50 men who undergo the procedure. Complications include severe bleeding, infection requiring hospitalization, and in rare cases life-threatening sepsis, especially risky for older adults with other health conditions. Now comes the bigger problem: overdiagnosis. Finding cancers that would never have caused any symptoms or shortened life, cancers that were simply sitting there quietly. Research estimates that for every 1,000 men screened with PSA over 10 years, about 100 will be diagnosed with prostate cancer, but only 1 or 2 would have their life extended by that early detection, which means the other 98 or 99 men were diagnosed and treated for cancers that would never have hurt them. And the treatment harms are severe and permanent. After surgery for prostate cancer, about 1 in 5 men develop long-term urinary incontinence, needing pads daily. And 2 out of 3 men experience long-term erectile dysfunction, problems that profoundly affect quality of life and relationships, all for a cancer. That likely would not have caused trouble, and radiation therapy carries its own risks: bowel problems, bladder irritation, fatigue, and secondary cancers years later. The emotional toll is also real. Living with a cancer diagnosis, even a slow one, causes anxiety and distress, and many men report regretting aggressive treatment. What you should do instead: have an honest conversation with your doctor about your overall health, life expectancy, and what matters most to you in quality of life. If you are over 70 with other serious health conditions, or your life expectancy is less than 10 years, PSA screening is very unlikely to help you. One critical warning: if you develop symptoms like difficulty urinating, blood in urine, unexplained weight loss or bone pain, those need evaluation immediately. Symptoms are completely different from screening, and the decision to test should always be individualized, never automatic, and never based on age alone. Test number 4. The Pap smear or human papillomavirus test for cervical cancer screening in women over 65 who have had adequate prior normal screening. If you are over 65, have had regular normal Pap tests or HPV tests in the past, and are not at high risk, national guidelines say you can stop. The reason is clear. Cervical cancer takes many years to develop, and if your previous screenings were normal, the chance of developing cancer now is extremely low. One large analysis found that continuing screening after 65 in women with adequate prior normal results prevents less than 1 additional case of cervical cancer per 1,000 women. But it leads to dozens of false positives, unnecessary colposcopies, biopsies, and treatments that carry real risks, especially as the cervix changes with age. Here is how the harm happens. After menopause, normal age-related changes in cervical cells can look abnormal under the microscope, triggering false alarms. You get called back for a colposcopy, a procedure where the doctor examines your cervix with a magnifying instrument and takes tissue samples, which can cause bleeding, infection, and significant anxiety. And even if the biopsy shows nothing serious, you have gone through discomfort and worry for no benefit at all. Another issue is overtreatment. Sometimes minor cell changes are treated aggressively, with procedures like cryotherapy or loop electrosurgical excision causing scarring and pain. When those changes would have resolved on their own, or were never going to progress to cancer in the first place, pure unnecessary intervention. The guidelines are specific. Women aged 65 and older who have had adequate prior screening defined as 3 consecutive normal Pap tests or 2 consecutive normal HPV tests within the past 10 years, with the most recent test within the past 5 years, and who are not otherwise at high risk, do not need further screening. High risk means having a history of cervical precancer or cancer, HIV infection, a weakened immune system, or exposure to a medication called diethylstilbestrol before birth. If any of those apply, the recommendation changes, and you should continue screening, so this is not a blanket rule for everyone, only for average-risk women. What you should do instead: confirm with your doctor that your prior screening history meets the criteria, and if it does, you can confidently stop routine testing. Redirect your energy toward other preventive care that clearly benefits women at this age: bone density screening for osteoporosis, which is critically important after menopause; breast cancer screening with mammography, which still has value into the 70s depending on your health; and cardiovascular risk management, the leading cause of death. One critical warning: if you develop any symptoms, bleeding after menopause, unusual discharge, pelvic pain, or any change, see your doctor immediately for evaluation. Symptoms always require assessment regardless of screening guidelines, and stopping routine screening does not mean ignoring warning signs. Those are completely different situations. The bottom line is that continuing cervical cancer screening after 65 with adequate prior normals adds minimal benefit but real harms, so stopping is the smarter choice. Test number 5. A routine colonoscopy at advanced age or with limited life expectancy, the test people are told never to skip, the gold standard. This is the most surprising one because colonoscopy is so strongly promoted, but the evidence shows that after a certain age or health status, harms outweigh benefits. National guidelines state that the decision to screen adults aged 76 to 85 should be individualized based on overall health and prior screening history. And in adults 86 or older, competing causes of death likely preclude any survival benefit that would outweigh the harms, so routine screening is not recommended. Here is why. Colorectal cancer takes 10 to 15 years to develop from a polyp, so if your life expectancy is less than 10 years due to age, or other serious health conditions like heart failure, advanced lung disease, or dementia, you will not live long enough to benefit from finding early cancer. But you absolutely will face the immediate risks of the colonoscopy itself, and those risks increase significantly with age and frailty, making the procedure more dangerous. Major medical guidance notes clearly that harms from colonoscopy, such as perforation, where the scope tears the colon wall, and bleeding increase with age, especially after 75. Perforation requires emergency surgery and can be life-threatening in older adults, and even without perforation, the bowel preparation itself carries serious risks at this age. The prep, where you drink large amounts of laxative solution to clean out your colon, can cause severe dehydration, electrolyte imbalances, kidney injury, and falls. For someone with heart problems or kidney disease, that dehydration and electrolyte shift can trigger heart rhythm problems or even heart failure, landing you in the hospital. And here is the critical data. Research shows that few additional life years are gained when screening continues past age 75 among average-risk adults already adequately screened. One large study calculated that if you had normal colonoscopies in your 50s and 60s, continuing screening into your late 70s and 80s prevents less than 1 additional death per 1,000 people screened, but it causes dozens of serious complications, hospitalizations, and procedures, meaning far more people are harmed than helped. The math is clear. Another major issue is overdiagnosis and overtreatment, finding polyps or early cancers that would never have caused symptoms or shortened your life, but now require treatment. That treatment might include surgery with all its risks, chemotherapy with severe side effects, or radiation, all of which significantly impact your quality of life in your remaining years. What you should do instead: have an open conversation with your doctor about your overall health, other medical conditions, and realistic life expectancy, not just your age. If you are over 75 and have been regularly screened before with normal results, or if you have serious health problems that limit your life expectancy, discuss stopping screening. Redirect your focus to things that clearly improve quality of life at this age: managing chronic conditions well, staying mobile and preventing falls, maintaining social connections. And here is the empowering truth: declining a colonoscopy at advanced age is not refusing care. It is making a wise, evidence-based decision that protects you from harm. Here is your action plan. First, make a list of any screening tests you are currently getting or have been told you need. Write them down clearly. Second, for each test, ask your doctor these 4 questions. Do I really need it? Will this result actually change my treatment? What happens if I wait? And what are the risks or simpler options? These are the exact questions recommended by the Choosing Wisely campaign, designed to prevent unnecessary care. Third, discuss your overall health and life expectancy honestly, because the decision should be based on those factors, not your age alone or a blanket rule. Now, a word of caution. Every one of these decisions is individual, and you should never stop a test on your own without discussing it with your doctor first. If you have symptoms, a personal history of cancer, high-risk conditions, or other factors, the recommendations change, so talk it through with someone who knows your full story. Imagine waking up tomorrow knowing that you are not over-tested, not over-treated, just focused on what truly protects your health and quality of life. If this video helped you see testing in a new way, please give it a like, share it with someone who needs this information, and check out the 2 recommended videos. Thank you for watching. Take care of yourself, and remember that sometimes the smartest decision is knowing when to say no to a test. Thank you for watching. Take care of yourself, and remember that sometimes the smartest decision is knowing when to say no to a test.